Hello everyone, thank you for coming. Welcome to this session of NAUTO's 36th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you will be able to enter comments and questions in the audience chat. We hope you will take advantage of this opportunity to engage with our speakers. This session is being recorded. The recording will be available in approximately 1 day by returning to this session in the agenda. We recognize and thank our Petabyte sponsor, the California Healthcare Foundation. All conference sponsors have virtual booths available during the conference in the sponsors section. At the booths, you can learn more about the sponsors, review materials, request contact, and collect game tokens. We hope all attendees will take a few minutes to visit each sponsor's booth. During each conference session, watch for a game token that you can collect for a chance to win a grand prize worth $250 or one of several prizes worth $50. Now I will turn the stage over to Norm Thurston, NAUTO's Executive Director, who will start today's session. Norm, you have.
Thank you, Marin. It's good to be with you again this year. My name is Norm Thurston, Executive Director here at NAUTO, and I am pleased to present our first forum on preserving secure and sustainable access to healthcare data. Today's first session will be news from State APCDs, and the organizer of the session has been Tanya Bernstein from Freedman Healthcare. We want to give a special recognition to our forum sponsor. They're not just sponsoring this session, they're sponsoring the entire forum, IBM Watson Health, and we would encourage you to visit IBM Watson Health's sponsor booth on the screen to your left at some point. With that, I'm going to bring Tanya to the stage. Tanya, welcome. The time is now yours.
Great, thank you. Hi, everyone. Welcome to today's NAUTO pre-conference event. This afternoon, we'll be hearing news from State APCDs. We have 3 sets of panelists today representing 3 states that are at different phases of their APCD planning and implementation process. So you will hear from California, Maryland, and Georgia. From California, we have Jill Yegian and Michael Valle. Michael is the Deputy Director and Chief Information Officer at what was formerly the California Office of Statewide Health and Planning Development. Jill is Executive Director of Yegian Health Insights, and she's also been working very closely with the California APCD team. From Maryland, we have Mahi Solomon, who serves as the Chief of Public Reporting and Data Release at the Maryland Healthcare Commission. And from Georgia, we have Samantha Lie-Tjauw, Senior Research Scientist from the Georgia Tech Research Institute. So we're going to hear from all of our panelists. We'll hear the presentations first, and then we will have time for questions. If you have questions, please enter them into the chat as we go, and we'll try to collate and get to as many of them as we can before the end of today's session. So with that, let's go ahead and begin our presentations.
Hi, my name is Samantha Lie-Tjauw. I'm a Senior Research Scientist at the Georgia Tech Research Institute, and I'm here to talk to you today about Georgia's APCD, background and opportunities. So at the state of Georgia, we have a very diverse population, and this represents a unique opportunity for establishing an all-payer claims database. We believe that the successful creation of an APCD in Georgia will enable insight into its complex healthcare system, probably some insight that we've never had before, and will really provide researchers and policymakers with critical data needed to identify disparities in health and access to care. So next, I want to give you a snapshot of Georgia. So welcome to Georgia. Our population is 10.7 million people. And again, like I said, very diverse population where 50% are represented by minorities, 31% being Black, 10% identifying as Latinx, 9% representing other minorities. And all the minorities also live in a various array of places across the state. 43% of the population in urban communities are represented by minorities, while 22% of the population in rural communities is represented by minorities. From a health insurance perspective, about 16% under the age of 65 are currently uninsured, and of the insured, approximately 50% receive employer-based insurance and 30% are on Medicare and Medicaid benefits. Similar to the rest of the United States, our leading cause of death is heart disease here in Georgia. Other Leading causes of death kind of in our top 10 in Georgia include stroke, diabetes, as well as kidney disease. Comorbidities such as obesity, which I know and we all know is a problem across the United States, really disproportionately impacts minority populations. So it's really through the creation of this GAPCD that we believe will help researchers, policymakers, employers, healthcare organizations gain access to the data needed to further identify those health disparities and identify the disparities in health outcomes, needs assessments, and really opportunities for intervention so that we can look different. So this snapshot doesn't look as dire as some pieces of it look. So we have a lot of opportunity for improvement here in Georgia. And for the APCD, what kind of brought it into the forefront is Senate Bill 482, which is the legal provision for the state's all-payer claims database. And it really includes the provision of a lot of things that it outlines. So we're talking about definitions surrounding APCD language, the establishment of an advisory committee. And so this committee would not only oversee the kind of design and implementation of the APCD, but also its kind of maintenance and use and impact as it moves forward. It gives guidance for the composition of that advisory committee as well as the duties that it would perform. It provides the provision of private and public funding for the database, outlines the objectives of the APCD, why we're establishing the APCD, defines the administrator of the APCD, as well as design criteria, among other things. So in regards to GAPCD objectives, the Senate Bill 482 really says this in plain language here. The objectives of the GAPCDs shall be to facilitate data-driven, evidence-based improvements in access, quality, and cost of healthcare, and to promote and improve public health through the understanding of healthcare expenditure patterns and operation and performance of the healthcare system. So this is really an opportunity for the state and its partners to come together and to make this happen, right? And the specific uses of the GAPCD as outlined in the bill include, but are not limited to, establishing baseline healthcare cost information, providing that to the public, making that public knowledge, increasing transparency, monitoring and analyzing healthcare costs. Again, part of that finance information, those expenditure patterns, as well as monitoring population and assessing population health. And so it's something that we really, really would like to get a better hold on in our state, having something that's a bit more accurate representation of our population health. Measuring the utilization of healthcare services, identifying health disparities, I know that's kind of common in what I've said in several slides now, and informing consumers again of cost and quality of healthcare so that consumers are empowered with that information, as well as supporting the planning and evaluation of healthcare operations and care, improving the coordination of care. We know that care is so complicated and involves so many different entities. So really looking at using data to improve the coordination of that care, providing that information across the board. Enabling oversight of healthcare insurance premium medical loss ratios and conducting waste, fraud, and abuse studies. So really getting at that cost of healthcare, getting at those expenditures to understand what's really happening under the hood. So Senate Bill 482 goes on to establish the administrator, like I was talking about. So what it does is it sets the advisory committee composition to include specifically the director of the Center for Health Analytics and Informatics, also known as CHI, at the Georgia Institute of Technology. So that is Dr. John Duke. So really it embeds directly Georgia Tech and a representative from Georgia Tech in that advisory committee. Not only does it do that, but it also establishes Georgia Tech itself as the administrator of the APCD. Some of the duties of the administrator as outlined in the bill include determining what data needs to be collected, establishing those agreements for voluntary reporting, as well as the kind of actually having to obtain Medicare health claims data, determining what measures are necessary to implement reporting requirements, also deciding what data will be publicly available, what reports will be publicly available, overseeing the collection, aggregation, distribution, and the public reporting of performance data, so how well the APCD is doing. Of course, protecting patient privacy, that is paramount. And then also providing leadership and coordination of public and private healthcare quality and performance measurements. So as the designated administrator per GAPCD legislation, we really believe in taking a partner approach to APCD implementation. So I want to tell you a little bit more about Georgia Tech and specifically GTRI. So the Georgia Tech Research Institute, or GTRI, is the applied research arm of the Georgia Institute of Technology, and it was founded in 1934. Currently, we're performing $660 million of problem-solving research annually for a wide array of partners, which I'll talk about on the next slide. We have a lot of technical experience. You'll see that in this figure to the right here. So we really demonstrate technical excellence in many different areas, and we're really going to bring that to the table with this GAPCD implementation. So anywhere from data visualization, analytics, clinical phenotyping, all the way to public policy, building stakeholder relationships, and human systems engineering. As an academic institution, we also really focus on building open source technology, so I really wanted to call that one out on the figure to the right as well. We do that whenever possible, and we develop systems that can be extended to multiple use cases and domains. Part of GTRI is that Center for Health Analytics and Informatics, and so that's something that I had mentioned earlier, CHI, right? And so I want to talk a little bit about the goals of CHI, because that CHI really is kind of the forefront of where we're doing our health analytics. And so the goals of CHI include advancing foundational technologies in health data analytics, supporting partners in maximizing the value of their health data resources, facilitating targeted delivery of information to patients, lawmakers, providers, as well as regulators, fostering scalable and secure real-world data research, both nationally and globally. So really looking at leveraging this vast array of technical capabilities and the deep pockets of past performance that we have in these areas, and bringing those to the Georgia APCD to make sure that we're creating a holistic approach and that GTRI can really handle all of the complex pieces that will, definitely happen and be required to handle in order to implement an APC for the state. So talking about those diverse partnerships, so here is a lot of what we work with, a lot of who we work with, and so you'll see here representation in our state, our in-state healthcare systems, as well as things at the federal level, such as the VA, the CDC, the FDA, NIH. We also have worked with tech companies, as well as insurers such as Anthem, pharmaceutical companies, and so we have a wide array of relationships and partnerships that we're planning on bringing to the table in terms of implementing this Georgia APCD. So we're deeply embedded in local communities as well as surrounding businesses and healthcare organizations, as you can see. We plan on leveraging these relationships to engage stakeholders and to build confidence and increase buy-in across the state. As the APCD administrator, GTRI will prioritize a transdisciplinary and collaborative approach. We don't think that any one way is the solution to do this, and that's how we solve all of our problems that with our clients and our sponsors that we have at GTRI, is we're really using a very co-creative and collaborative approach and working across all of the disciplines necessary, from computer science to public health to healthcare analytics. As an academic institution, again, we're part of the state of Georgia, and we work closely with so many other agencies. So we believe that we're really uniquely positioned to apply a diverse array of methods to understanding the needs of our stakeholders and ensuring that these are reflected in Georgia's APCD, both in the short-term development of it as well as the long-term maintenance. We believe that this approach will maximize the value of the APCD as an engine for improved healthcare outcomes, cost transparency, and quality in Georgia. So thank you so much for your time today. Really appreciate it. Looking forward to hearing the questions that you have and being part of this panel. And if you'd like to get in touch with me so we can share lessons learned from other state partners, we would love to do that. And as well as ask any questions that you may have of us, you can see my contact information there. Thank you so much.
Great. Thank you so much, Samantha. It is so great to hear from a new APCD state, especially one that is, just beginning to think about the implementation and planning process. And I'm sure we're all eager to hear the progress from Georgia over the coming months. So thank you again. Just another reminder for everyone to please put any questions you have in the comment box. Even though we are virtual, we're trying to make this as interactive as possible, and we'll go through all the questions at the end. All right, so let's hear from our colleagues in California next. Norm?
Hello, National Association of Health Data Organization pre-conference attendees and everyone watching. It is wonderful to be with you. Michael Valle, Deputy Director for Information Services and Chief Information Officer at the California Office of Statewide Health Planning and Development. I'm thrilled to be joined today by Dr. Jill Yegian, Executive Director of Yegian Health Insights and close partner and consultant who has been working with our team for several years. Today, we'll be speaking with you about our experience in building the nation's largest APCD in California, what we call the Healthcare Payments Database, or HPD, and to share with you our early experiences to date through several years of planning, now moving into design and implementation of this critical healthcare data resource. Right off the bat, I'd like to thank the National Association of Health Data Organizations, the APCD Council, and so many others that, if not for their time, attention, and help, we would not be at the place we are today in California. Truly grateful for all of your support, happy to share what we've learned so far, and look forward to giving back to this community of data experts and innovators and partnering with all of our friends in other states wherever we can. First, we are so proud to announce that our organization, the California Office of Statewide Health Planning and Development, is becoming the Department of Healthcare Access and Information, or HCAI. This change is additive. We'll be doubling down, expanding our healthcare data analytics portfolio, and evolving our healthcare workforce development programs to zero in on affordability, equity, and access to culturally competent care. This change represents an acknowledgement of the vision and path that this organization is on and has been on for many years, and the confidence that many different groups, policymakers, and our constituents have in us to achieve that vision and improve access to affordable, quality healthcare for all Californians. And it's a storied history indeed. We've been doing healthcare data analytics and supporting informed decisions for over 40 years in the areas of healthcare facility finances, hospital performance outcomes, prescription drug cost trends, and more, providing an important lens at how the delivery system is doing and supporting population health as well. We have continued to scale and evolve our data and analytics capabilities and practices. We have published some important and informative analytics and visualizations, and there's a link later on in the presentation where you can view all of our recent releases, which has all been preparatory and leading up to the Healthcare Payments Database, the HPD, California's APCD. We're using the term healthcare payments to recognize the future of value-based care and the prevalence of managed care in the state of California. Building the Healthcare Payments Database is one of, if not the, largest undertakings in our department's history. Aggregating as many healthcare claims and encounters as we can across care settings for as many of California's 40 million residents as possible, likely resulting in billions of data records a year. And our goal truly is to help move the needle and make tangible impact for Californians. We started in 2019 after the California legislature asked us to develop a plan for how to build such a database in the state. And we were provided $60 million in seed funding as an upfront commitment and investment in the work. We convened a fabulous and diverse group of experts. The result, after 12 committee meetings, and was 36 unanimously approved recommendations for how to develop an all-payer claims database in California. And the consensus, which we documented in the 2020 report to the California legislature, is that this is something we could do, it is something that we should do, build this powerful research database in the state. Since then, we've been heads down, designing, developing, and building up the program, expanding our infrastructure, bringing in some key technology partners, engaging with data submitters, and scaling our team. I'm excited about where we are and how we can continue to advance our mission to achieve access to safe, quality healthcare for all. And again, I'd like to thank NATO, the APCD Council, all the states that have come before, and the fabulous California team. And now I'll turn it over to Dr. Yegian, for a discussion of California's early experiences to date. Jill?
Thanks, Mike, and thanks to NATO for convening this session. And reflecting on the early experience of working with the fantastic OSHPD team on developing the healthcare payments database, 4 aspects emerged as worthy of sharing with others. The first is listen to stakeholders. Mike mentioned the multi-stakeholder review committee that met monthly for a year to advise OSHPD on the design of the HPD, creating a comprehensive set of recommendations that inform the enabling statute. A new advisory committee now meets quarterly to advise on implementation. Its members have diverse perspectives and represent key constituencies. Their logos are displayed on the slide. All the members are committed to greater transparency and are willing to remove their organizational hats and represent the broader community. Under California law, meetings are completely open. Agendas and materials are posted in advance. The public is welcome to participate, and each meeting includes time for public comment. The second element of our early experience is learn from experts. There's a large and growing body of knowledge on APCDs, and the HPD team has benefited enormously from the expertise in the field. NATO and the APCD Council have served as advisors from the outset, and the contract team includes Freedman Healthcare. Many APCD leaders generously have shared their experience with the HPD team during the design process, and several APCD leaders presented to the new advisory committee this year, including Civic and Virginia Health Information. The development process has also benefited from expert analysis. UC San Francisco conducted a legal analysis of payment data transparency, and the Public Policy Institute of California did a deep dive on researcher use cases. The California Healthcare Foundation has been a great supporter of the HPD effort, contributing funding for both of these analyses. The third element of our reflection on early experience is rely on national standards. Leadership from NATO and the APCD Council has been essential in this area. HPD adopted the APCD Common Data Layout, and that is specified in the enabling statute. Engagement in the APCD CDL process started in 2019 when the team convened a technical work group of health plans, insurers, and other stakeholders to provide input on California's requests for changes to the layout. Active engagement is ongoing. The HPD team is looking to NATO on non-claims payment data, which will be essential given that capitation and alternative payment models play a major role in California's market. And on private self-insured data submission, we are looking to the Department of Labor's State All-Payer Claims Databases Advisory Committee for standard setting. The fourth and final element is engage submitters early. Submitter engagement started at the planning stage prior to passage of enabling legislation. HPD has benefited from the active, constructive participation of trade associations for health plans and insurers on the review committee and the advisory committee. Outreach to mandatory submitters started in the fall of 2020. The first wave focused on health plans and insurers prioritized by size. We have created a distinct work stream for public self-insured entities. To date, 29 meetings have been held with submitters, with 14 follow-up technical meetings, and outreach is ongoing. A data submitters group launched in July and will have an ongoing quarterly cadence. A data submitters landing page is available at the OSHPD website, including an FAQ and distribution list for updates. Significant time and resources have been invested in building relationships, communicating, laying the groundwork for 2022 data collection. The team continues to climb a steep learning curve almost 3 years into the process. It has been challenging and rewarding and has benefited tremendously from the broad and deep community of APCDs and other health data organizations across the country. Mike, back to you to wrap this up.
Thank you, Jill. As a final thought, and I think this applies to many programs and projects and work, especially in government and the public sector, and that is, it's a balancing act. Tapping into the thrill and excitement and the promise of what the HPD can be, which is essential to obtaining buy-in from diverse interests, gaining their support, and securing sustainable funding. And doing that while maintaining expectations. We know this is a lift. It's new, it's big. We want to understand the data, make sure it's quality, make sure it's usable, and get it right. All the while, we have heard from stakeholders that we're 10 years behind. in having this critical understanding of the $300 billion healthcare economy in California and serving the most diverse population in the nation, while also needing to keep a team of the most dedicated, unsung civil servants engaged and feeling valued and supported so they can get things done. And so what stands out to me most is this: keep the goal, the impact, the user, the consumer, the patient in your view. It's where you're driving to, what you're investing in, and why you're taking the trip. But also be transparent, upfront, and realistic with everyone who's along for the ride to make it a success. And with that, we've included some resources and links that may interest you, including our 2020 report to the California Legislature and how you can stay connected with us, follow our progress, and get engaged. Thank you all for your time. Happy to take any questions or hear any feedback that you may have. Thank you.
Great. Thank you so much, Michael and Jill. California's effort is so impressive, especially due to your dedication to stakeholder and community advisor engagement. So I'm sure we'll have some questions regarding that at the end. I'd like to introduce our final presenter from Maryland, that would be Mahi.
Good afternoon, everyone. I'll be presenting Maryland's experience in its data release modernization process. Just to give a high-level background, MHCC has been releasing the MCDB data, which is the APCD data, since 2001 in different capacity to other state government entities like the Health Services Cost Review Commission and the Maryland Insurance Association, and for research institutes like the University of Maryland and Johns Hopkins University. With the maturation of the MCDB data, it was compelling and timely to work on expanding the use of data beyond what was currently being done, and the regulation was outdated and limited to what we wanted to do. To that end, in 2017, MHCC partnered with the Johns Hopkins School of Public Health to test the utility of the MCDB data for research use. The experience from the various use cases served as a foundation to plan out the approach for the modernization of the data release process. In terms of our approach, which I'll go over in detail in the next few slides, first we assessed the current state, which we also call the reason for change, and scoped out where we wanted to be in terms of the future state. And we wanted that to be based on the understanding of the benefits and implementation fidelity. This required identifying interventions and techniques for the transition, which we also known as the change process. Some of the major reasons for change for the current state were things like the requirement of the IRB for all types of requests, which subsequently meant only research organizations were eligible. And in other words, only applicants that want to do price transparency initiatives were not eligible. At the time, only full year of the MCDB data was available for release, even though MHCC collects other sensitive data such as trauma patients, Medicare minimum data set, and the current regulation applied only to the MCDB data. In addition, the application form, review guideline, approval standard were all unclear as the regulation was outdated and somewhat vague. The plan also included updating the current website housing the data release information to make it more intuitive and easy to access. Moving on to the change process, which is the transition, the areas of improvement could be broadly classified into these 4 buckets, which is the update of the regulation, developing a new application package, streamlining the application review process and the documentation, and lastly, improving the website. The future state, as we envisioned it, will have an expanded use of the APCD data, diversifying the types of data sets provided, expanding the eligible organizations that are able to apply for the data and eligible for receipt of the data. the development of a comprehensive application and pre-application package, which would include a data management plan with appropriate questions and a template for the data use agreement. And also aligning the review standards for the Medicaid data that is part of the MCDB was also another goal of this modernization process. Also, creating a transparent and thorough review process, and lastly, updating the website with information and where to apply and the cost of the data. So what is the long-term goal and wider benefit of this initiative? It is to execute the mission of MACC, fulfill the vision, and also meet the strategic goal of 2019, which is to make MACC the trusted source of quality and cost information. So in order to specifically identify what we needed to do, we looked at 6 other state APCDs to identify gaps and opportunities for improvement. There's a lot of detailed data collected behind these data points, but for the purpose of viewing, we'll be using just gray and darker gray shade to depict the status of the specific domain. Overall, we looked at the presence of a standing data release committee or advisory committee that is in charge of the process, the types of data provided, who can request, and the presence of the different application types. We also looked at what is the most current data or year of data available, and also data release decision-making process, and overall post-data receipt monitoring process. Based on this gap analysis, we were able to identify best practices in the areas of developing a robust application package and advancement of the review process and critical updates to the regulation. And as part of the adoption process, hearing from individuals that understand the healthcare landscape in Maryland was important to us. So relying on their expertise to gain their insight and valuable feedback and buy-in on the revision to the regulation was critical. Based on the best practices and the feedback from stakeholders, the revision consisted of the type of data set offered. It identified a separate request and review process for government entities. And the revision also included requiring non-government applicants to demonstrate their research topic or project to be within the public interest. It also included establishing a new fee structure, improving the transparency of the data request and the data release process overall. And lastly, in terms of the process, it included establishing a work group. Like I said earlier, we wanted to engage stakeholders, and the work group comprised of state agencies, provider groups, consumers, payers, and researchers. This group met 3 times to discuss and finalize their feedback. And once the work group completed their work, the proposed regulation was presented to the Commission for adoption and is currently posted on the Maryland Registry for public comments. The proposed final regulation is expected to be adopted and in effect by November. This concludes my presentation. Thank you for listening. I welcome any questions.
Great. Thank you so much, Mahi. Great to hear. Very interesting to hear how Maryland is rethinking their data release program. All right. I just want to remind everyone who's joining the session that the token, the session game token, is available on the screen, I believe. So that information is available. All right, so let's go through the questions that we've received. I guess I will start at the top. This question, the first one I believe was for Georgia. Does the enabling legislation that names Georgia Tech as the administrator of the APCD allow Georgia Tech to do so as an extension of the state health department specifically? Is going to be HIPAA covered?
Yes, so thank you so much for this question. It's definitely a great one, particularly because we're interestingly poised as the administrator. So we are doing so essentially as an extension of the health department, specifically the Department of Community Health here in Georgia, as well as the Office for Health strategy. And so we are partnering very closely with them. Kind of, they're letting us know, what we can and can't do, but we'll be the ones actually, operationally doing the implementation as well as critical in the design of it. And the State Bill 482 that I mentioned is specifically does, call out HIPAA, that it is HIPAA covered, and we'll make sure that we're compliant with all that as well.
Got it. Thank you, Samantha. All right, let's keep going. The next two are for California. Actually, they're related. So California, how do you intend to get payment data from payers using alternative payment methods, payment systems like Kaiser? What standard do you envision for collecting APM data?
Well, thanks for the question. And just again, I want to say thanks to Tanya and Norm and Nigatu for organizing this, and everyone for sharing. Let me go ahead and start with a couple remarks, and then I'll ask Dr. Yegian to add. I think to start is we are really focused on stakeholder engagement, as was mentioned in our presentation. So we're working very closely with all partners, and what we'd like to see is movement on national standards in the alternate payment space. We feel that that is an effective and important way to proceed forward. There's been some progress, is my understanding, in that area, and we're sort of hitching our wagon to how can California be a part of that trend to advance in that space. Of course, there are some methodological ways we can look at the claims data, but we'd love to see continued investment and advancement of national standards in that space. But Jill, anything you'd like to add?
On the issue specifically of the APMs, Mike, or are you moving on to the public reporting?
On APMs specifically.
Yeah, on APMs, I think Kaiser's an interesting case, and I think that in particular, it's worth noting that Kaiser has extensive experience with reporting on fee-for-service equivalents, and that has been tested and used in other states by other APCDs and is used extensively at Kaiser for business. So I think that while Kaiser is often held up as the reason that it is impossible to get comparative cost data across payers that include Kaiser, I think actually Kaiser has more experience reporting on fee-for-service equivalents than many of the other plans in a way that's robust. So that's the only piece I would add.
Great, that's very helpful. And then yes, that second part of John Freedman's question, what is California's plans for public reporting and how will you set that agenda?
Great, I'll start there, and then I'll also ask Jill to add on, and thanks for the question, John. It's really thrilling and exciting to begin thinking about how the data could be used and how transparency can help move the needle. What we're doing is starting with establishing principles and priorities for public reporting, and doing that in a collaborative manner with our stakeholder advisory committee. We'll be having a very important discussion on this topic in October, but really the goal is what lens should the state be looking through, what public reporting can produce the most impact, while also, as we mentioned in our presentation, managing expectations. We'd like to think about how this can be an all-in approach, where the state and researchers and others who have access to data can help contribute to a public reporting agenda that supports transparency broadly across the board. And again, we'll be having a discussion in October that Dr. Yegian will be leading. So Jill, anything you want to add on that?
Sure, and I appreciate that the question came from John, and John and his team have been tremendously helpful in articulating that agenda for California. I would just make one other comment to add to what Mike said, which is that we're really thinking about this as a phased approach. We need to both, it's sort of back to that tightrope that Mike talked about earlier. We have tremendous aspirations for what public data can be done with HPD for the benefit of Californians. And at the same time, we need to really sequence that carefully to ensure that the initial reporting on the core medical and pharmacy data is solid and locked down before moving on to more complex and sophisticated and ambitious forms of public reporting, which we absolutely intend to do. But we want to make sure that we have the data maturity in place, the capabilities in place, and the stakeholder engagement well laid so that we're phasing in that public reporting over time.
Thank you, Jill. Before we move on to some of the questions for all of the panelists, and since Marilyn spoke specifically about the data release process, I wanted to ask Mahi, did you encounter any concerns from your commissioners or other leadership when you began conversations about revising your data release process?
Thanks for that question, Tanya. I guess I could say yes and no. This is particularly related to having a separate request for government entities and non-government entities, and how that impacts the fee waiver structure that we have in place. So basically, we have these criteria for a fee waiver for certain applicants, and in that, commissioners wanted to look at how federal projects that are funded by the federal entities, what their redisclosure of the output of the project is going to be in terms of publication, and that is tied to a funding, the funding requirements as well. So we wanted applicants to list out those requirements related to their funding source, so that Maryland is aware of what is expected from the applicants when the DRAC, which is the Data Release Review Committee, looks at the application itself. So that was one component. And since the application that is submitted to AMHCC will be published publicly, and also the output, we wanted to ensure that these were not really tied to any funding requirements the applicant might have. So yeah, those are the kind of concerns that we addressed through the update for the regulation.
Got it. Thank you. All right. Elizabeth Davidson asks, can panelists reflect on how the COVID-19 pandemic has affected their plans and progress? For example, state funding concerns or refocus of health data initiatives to reflect COVID issues? Who'd like to start? It's impacted all of us in every way, right?
Well, I'm happy to start from the California perspective. I think, one in our circumstance, we were fortunate to have an upfront investment that preceded the pandemic. That's been helpful to have that stable source. But I think too, in some ways, the public health crisis has only emphasized the need to have an investment in a data infrastructure that can help us respond from a population health standpoint. So from what I've seen in California, the interest from policymakers and leadership has only increased in understanding that data is an asset, and we need to have the infrastructure in place prior to the crisis to be able to improve response. And so we're looking forward to building something that can provide insights ahead of future public health challenges to come.
I can go next. Yeah, I think we had similar experience in Maryland as well, particularly data requests for recent, recent in a sense like 2020 data and 2021 data. So, and these were from entities that we hadn't had any requests in the past, the types of organizations, that was what I mean. So we wanted to really expedite this process so that we can have, first of all, have more data available for applicants, and also have more diverse applicants that will be eligible to apply for the data. And this is definitely related to COVID, because most of the use cases that were listed on these applications were really related to identifying the impact of COVID, and some requests had related to delayed care and impacts on chronic illnesses. So these were really focused on care management as well. So which we didn't have. We didn't have these requests in the past. So really, COVID had an impact on that, and that actually helped us to kind of move this forward more quickly and emphasize on the importance of an updated and a modernized process.
Great. Yeah, I'll add, I know in some states, the APCD program has been able to leverage funding through either the CARES Act or American Rescue Plan dollars, either directly funding a component of the work, or more often funding analyses that request the APCD data, and kind of making a value proposition for the APCD by saying, hey, those analytics that are being run right now through the federal grant money programs can be fulfilled with the APCD. So that's an opportunity, silver lining there.
Well, and I think I would just add, Tanya, that several APCDs that I've seen have done a very nice job producing some visualizations and data access for their data user communities that pull in COVID considerations and even help sort of with on-the-ground identification of at-risk populations, tracking of utilization, and then, of course, longer term, what COVID has done is just put a very big spotlight on the existing issue of health disparities and equity, and just really emphasize the importance, as Mike noted, of gathering up this data and having the resource available so that it can be deployed for all kinds of purposes on quick turnaround. The resource issues are real, and there will continue to be those trade-offs. But I think from our perspective, it's just highlighted the importance and the priority and the value of the resource.
Absolutely. I think next week during the main NATO presentations, we have a slew of examples from states on those kind of immediate impacts of COVID, long-term impacts, and using APCD data to support those analyses. So absolutely. All right, keep those questions coming. I do have a little bit of a reserve of questions, so I'll start going through those. The first one for all of the panelists is regarding advisory committees. So a lot of states have anxiety about convening stakeholder groups or advisory committees. What factors contributed to the success that you experienced in California or Maryland? And I guess for Samantha, to what extent is Georgia beginning to think about a stakeholder or advisory committee process? So who'd like to start?
I'll start for Georgia. So yeah, we are in the very early phases here, and so we will convene our advisory committee group for the first time next month, actually. And so we've appointed, the individuals in the different roles, which took a little longer than we anticipated. Making sure that the right approvals were in place, the right representation, across the board. Is there on the committee. So, and then we'll have subcommittees as well. And so it's just kind of, it's been interesting getting all those moving pieces together. And, kind of related to the question that was asked earlier in regards to Georgia Tech, we're playing a role in that, but then the selection is really being guided by the Department of Community Health. So it's interesting seeing the ebb and flow and push and pull of, we're really eager, the state's really eager, but it takes a little bit of time. So we'll be excited to share more with the community as we get started at the end of October.
Thank you, Samantha. Others, any advice on successful advisory committees or stakeholder groups?
Well, happy to share a couple. Oh, please. I'm sorry. Go ahead.
Go ahead. No problem.
I'll just a couple of things I'll share. First, in terms of approach, we really focused on designing this policy committee around working with established associations and interest groups with the expectation that they would represent their membership and bring the perspectives of their constituents to the table. And these are folks that we're fortunate to have longstanding working relationships with and are familiar in working on public bodies, know one another in many cases, which I think has helped maintain decorum amongst some very diverse interests. It's also been really important, I think, to set expectations about the role, about what we're trying to accomplish, that their expertise is valued, and that we're working together to achieve a common vision. And Jill mentioned, removing your association hat when you enter the door. You're bringing the perspectives, but we're all working together towards a common purpose in that. And then finally, just in terms of process as well, we've really focused on trying to be transparent and honest with how we're approaching, our meetings and our structure, our decision making. And I think that members benefit from fitting into a structure, are happy to do so, and that when they know the rules of the road, they can support and participate in that. So those have been some, I think, lessons learned. And again, as evidenced by our presentation, we really spend a lot of time focusing on stakeholder engagement, and it's been important part of what we accomplished so far.
I would just add one thing quickly, which I agree with everything Mike said, and I would just add one thing, which is that for one thing we really try to hold each other accountable for is being mindful of what we're asking of the advisory committee and ensuring that we intend to use the information and the guidance that they provide us to influence what decisions are made. And and I think that's really key to ongoing active engagement with the members who really want to play a role and have a contribution to make. They want to have an impact and an influence. So really being thoughtful about what the key decisions are, where some things, the APCD leadership is going to know what needs to happen, and that's a matter of informing advisors. In many others, there are real opportunities to change the course of the trajectory, and those are where it's important to really gather that input and be mindful about what those issues are.
That's great advice. Thank you. Mahi, would you add something?
Yeah. So I was just going to add, especially from engaging in work groups or engaging stakeholders, I would say Maryland has a good experience in that, and particularly related to the APCD data, even any projects that are public reporting and other initiatives. We have experience engaging stakeholders in a form of work group. So that was very beneficial for us in terms of having a good relationship with our stakeholders, and also being able to effectively use their expertise as well. And since the APCD data is used by various entities like the Maryland Insurance Association and then other sister agencies, that's where we started. And also including and as mentioned in the presentation as well, we have Medicaid data included in the MCDB data, so we needed to also include stakeholder participation from those sister agencies like Medicaid, and also provider groups, because we frequently do public reporting that impacts providers and hospital associations. So we included their stakeholders from those groups. And also, since this is the data that's going to be redisclosed, even though it is fully de-identified, it was important to include the voice of consumer advocates as well. And we have had experience working with them in the past, so it was a very, I think, efficient and I would say a good, since we have an established good relationship, it was easy to get their feedback and their input in time, and also put in good, I would say, very significant language in there where emphasizing the protection of consumers as well. So and this is based on the feedback that we got from the workroom members. And I would say, I think I would echo what Jill has said earlier, being able to kind of be precise on what the ask is. And, even though it's also good to start early, but also be specific on what their engagement is going to look like and what the ask is and how to incorporate those feedback, and maybe have like multiple sessions and ensure that all the everyone is able to voice their concerns or provide their input, and then that also it has an impact in terms of also the timeline it takes, the time it takes to complete the work. So having that even one-to-one engagement with each member is going to be critical as well, and then have a precise ask from each member of what they really want to see. And sometimes try to work offline as well, and work one-on-one, and capture more feedback from those who have concerns and want to see change in what is being done. So that have been very beneficial for us here in Maryland.
Thank you, Mahi. Okay, it looks like we have time for one more question, which is perfect because we only have one more question. From Alfred Herrera. What were the business needs and use cases that catalyzed your APCD programs? Who wants to start? Was there a specific business need or use case? Was there a specific catalyst?
I could go and say, because Maryland is, it's an old, it's a mature APCD system, and the biggest driver for the creation is the rate review and the rate setting process that Maryland does, which is kind of different from other states, because it's the only state that does have a global budget system for hospitals. So that is driven, and the base data, I would say, and the foundational data for that rate setting process is the APCD data, and the biggest driver for the establishment of the APCD. And even though this has been going on for decades, that was the biggest driver. After that, there have been multiple projects that came out of the APCD data, and the recent endeavor is the data release for us. But in the past, we have multiple government agencies that utilizes this information, but the biggest driver is the global budget system and the all-payer system that Maryland has adopted. So those are the two biggest drivers.
Thank you, Mahi. Anyone else?
Well, I think we took a kitchen sink approach a bit in California. There's been interest in getting an APCD off the ground for a decade or more. So I think there's built up expectation that there's many use cases that could be solved. I think one really around trying to show trends in disparity and equity across regions, across populations is especially important for California, and something that we're going to be focused on.
And of course, I'll just add that one of the biggest value propositions for an APCD is the cross-payer, cross-setting aspect. So you're going to get the commercial and the Medicaid and the Medicare, and you just can't get that in any other data source. I'm a fan, so. All right, well, we are at the top of our time. I want to thank all of the panelists today. I think it's been very interesting to hear updates from all of the states. Thank you to Norm for putting on the conference, and we're all looking forward to next week's sessions and this afternoon sessions. Norm, do you have anything else to add before we conclude?
Thank you, everyone. Just a reminder, if you have not put in your code for the session, the code of safeguard, if you put that in right now, you can be entered in a chance to win some pretty significant prizes. But we'll see you all in about 15 minutes at our next session.
Great.
Thanks, everyone.
Thank you all.
Thank you.
For joining.